Hello, everyone. So this is the lecture on the care of patients with diabetes mellitus, and this is the only topic from the endocrine system in adult health too. So the first case study, setting office, the chief complaint, patient is becoming thirsty a lot or most of the time, and then the vital signs, respirations 12, blood pressure 144 over 92, and the HPI, which is the history of present illness, and age 53 years old, man, blood pressure borderline high, at the high level, and patient is presented with also signs and symptoms of diabetes mellitus. So the past medical history, obesity, and then the ROS, which is the review of systems, increased frequency of urination, so polyuria. Medications none, and the physical exam revealed normal findings. Just a percentage-wise in terms of the correlation between the hypertension and diabetes, there's about 73% of adults with diabetes or diabetic, they have hypertension. There are medications that would increase also the risk of diabetes, like corticosteroids, prednisone, one of them, thiazide diuretics, phenytoin, dilantin, which is anti-epileptic drug or anti-seizure drug, and other antipsychotic medications like clozapine, which is clozaril, which is a atypical antipsychotic drug. All these drugs may increase or increase the risk for diabetes mellitus in patients who take these drugs or medications. So the orders include KIM-7, CBC, urinalysis, lipid profile. When we see KIM-7, it's electrolytes, bond, creatinine, the CO2 and glucose. So the lipid profile, which includes the LDL, the HDL, and the triglyceride and the total cholesterol, all that will be included under the lipid profile or panel. So the KIM-7 came back, and these are the results from KIM-7. So just to know that the lifestyle modifications of weight loss and exercise have already failed in this patient. So there are two different types of diabetes. Type 1 diabetes, which is an autoinflammatory destruction of pancreas that will result in an insulin deficiency in type 1. Autoinflammatory destruction of the pancreas, which is responsible, as the Langerhans beta cells in the pancreas produce the insulin. So if there's destruction of these cells, then there is an insulin deficiency. And signs and symptoms will be polyphagia, polydipsia, polyuria, weight loss in in children or adolescent, and can lead to DKA in type 1. So that can lead to a DKA, diabetes ketoacidosis, which is a complication that will result from type 1 diabetes. And especially if they're under stress, or if they develop an infection, that could lead to that complication in type 1. So patients when they develop the DKA as a complication from type 1 diabetes mellitus, they exhibit what is called the Kussmaul respirations, deep labored breathing, become also dehydrated, and hyperkalemic. Because of the acidosis, they will become hyperkalemic, increased potassium level. We'll get to the treatment later on, like when the patient is diagnosed with DKA, what is the steps and the appropriate treatment for these people, for the patient during the DKA episode of diabetes ketoacidosis. But so that's type 1. Type 2, usually it's an adult onset because there is some residual insulin production. The pancreas is producing some insulin, but that's insufficient. So that's why patients are less likely than those with type 1 to develop DKA. They will develop something similar to that, but it's not DKA. It's called HHNKS, which is non-ketotic, hyperglycemic, hyperosmolar syndrome. So they become severely dehydrated, even more than patients would develop the DKA. You'll have polyphagia, polydipsia, polyuria, fatigue, weight loss. So in type 1, to treat the patient with a DKA, they have to receive, or we will put the patient on IV insulin drip to stop the acidosis. IV insulin drip is required to stop the acidosis in DKA. So the insulin is to shut off the acid production, not for the hyperglycemia. And the insulin must be continued until the ketone bodies or ketones or disappear from the blood. From the blood. So if the glucose levels falls below 200 milligram and the acidosis has not resolved, so you administer the dextrose intravenous, IV dextrose, until the acidosis has resolved. Also, in addition to the insulin drip, there is an administration of potassium. Unless potassium, some patients will have hyperkalemia, so we do not, start potassium right away, and unless the patient is hypokalemic. But in general, the first phase of DKA will be hyperkalemia. And eventually, in about 24 hours or 2 days, they become hypokalemic, and then we will administer the potassium. So type 2, when it's chronic, patient develop macrovascular or microvascular complications. Macrovascular, like stroke, coronary artery disease, CAD. Microvascular, like uh, retinal changes or nephritis or nephropathy, retinopathy, retina, ophthalmic problems, kidney problems. That's microvascular. And then the neuropathy, which is decreased sensation, paresthesia, numbness. To diagnose to diagnosis of any diabetes, type 1 or type 2, we have different lab diagnostic tests for testing. Random plasma over 200 with symptoms is diagnostic, or fasting glucose over 125, or 2 hours oral glucose tolerance test over 200 with or without symptoms, or hemoglobin A1C over 6.5%. There is also pre-diabetic state, which is when we say the patient is pre-diabetic, and that's when the impaired glucose tolerance test is done. So that's diagnostic for patients who are pre-diabetic, or they are pre-diabetic. The IGT, which is the impaired glucose tolerance, the IGT defined as a 2-hour oral glucose tolerance test of 140 up to 199, 140 up to 199, or fasting glucose from 100 up to 125. So the treatment would be, the patient would be on oral hypoglycemic, first line of management for mild to moderate hyperglycemia, diet and nutritional education. The ACE inhibitors, they can slow the progression of the nephropathy as a complication in patients with renal problems or tendency to develop renal problems, like patients who are hypertensive, for example. So the hemoglobin A1C, we can monitor the patient's compliance with regimen with hemoglobin A1C. Because of the serum half-life of hemoglobin, the hemoglobin A1C is a marker of the prior 3 months of therapeutic regimen. So you can monitor the patient over 3 months in terms of adherence, compliance with the medical regimen. So the tight glucose control, which means to control the hyperglycemia aggressively or with a tight plan or control, has revealed or has shown a reduction in complications and mortality in type 1 and type 2. Mortality rate and complication has declined with a tight glucose control. So the most important aspect or element of the management of patients with diabetes is the tight glucose control. So the hemoglobin A1C is a crucial key tool to follow the efficacy and compliance of diabetic treatment regimens. And what's recommended in patients who are diabetic is to have hemoglobin A1C less than 7%. That's recommended. Other textbooks would say less 6.5. So in patients with type 2, since they develop the HHNKS, the hyperosmolar, hyperglycemic, non-ketotic syndrome, they become severely dehydrated, profound dehydration, because they do not get the acidoses like in DKA, which would have prompted severe symptoms and an earlier presentation to the hospital too. So these patients can have out of control glucose for many days, even 2 weeks, and are more volume depletion. So they have fluid loss or volume depleted than the DKA patients. They will be presented to the hospital with severe dehydration, more than patients with DKA. In terms of dehydration, it's more in HHNKS than DKA. And their glucose level will be way higher than the patients with DKA, over 1,000 milligram. They'll have no acidoses. They will be confused, probably also have renal impairment. So they will be treated with aggressive rehydration. They will receive even more than 10 liters of fluid, insulin drip. The mortality is higher than in the HHNKS than the patients with DKA. And that the mortality will result from the cerebral edema. And that's due to significant changes in sodium and water level during the therapy. Now, the orders, in terms of medications, the patient on these meds. So the metformin is the first med, which is the best initial therapy for obesity-related type 2 diabetes, because it will not cause any hypoglycemia and will not increase weight. Other medications, they will cause hypoglycemia and also may increase weight. So this metformin, it will not cause hypoglycemia and it will not increase weight. Like sulfonylureas, for example. Sulfonylureas, they do both. They increase weight and they cause hypoglycemia. So weight loss and the exercise, if patients could do it, weight loss and the exercise would eliminate about 25% of diabetes immediately, because the exercising muscles or the muscle during the exercise does not need insulin. So the patients lab results came back, we said hemoglobin A1C 8.4, which is extremely high. Glucose was 218. And we said that the normal fasting should be below 100. And a person with pre-diabetes, they have a fasting between 100 and 125. And we talk about also the oral glucose tolerance test earlier. So what is the mechanism of the patient's polyuria? Why the patient develop the polyuria um, due to the diabetes? So SGLT, which is the sodium glucose contransporter, number 2, that's present in the proximal tubules. So there is a threshold for beginning to spill glucose into urine. That's when the glucose blood level or the serum glucose level is above about like 180 or up to 200. So that's the threshold. So once that, for blood glucose, to be present in the urine, so that threshold for these tubules to not to allow leakage of glucose into the urine. So until the glucose is higher than 180 or 200. Now this level drops with age, and older adult or older, people, um, older people, they will spill glucose into urine at a lower blood glucose level than 180 or 200. So the patient returns in 1 week. Symptoms of thirst and polyuria improved to a large extent. Um, and patient is fully adherent to the metformin and statins. So the metformin works by blocking the gluconeogenesis, which is the conversion of protein to glucose. It will prevent that. It will block the conversion of protein to glucose, which is gluconeogenesis. That's the mechanism of action of metformin. So because the metformin, it doesn't increase insulin level, so it doesn't increase weight gain. And because the patient has a microalbuminuria, which is an indication of kidney impairment or renal impairment, so the ACE inhibitor should be started. So the patient should be on ACE inhibitor because we said that it will delay the progression of the disease, of the renal impairment. So it's kind of protective to patients with renal injury or in the or beginning phases of the renal problem like microalbuminuria, for example, or proteinuria. So the blood pressure goal for patients who are diabetic is less than 130 over 80. So that's, so the patient should be started on ACE inhibitors to control the blood pressure as well. It will take care of blood pressure, and also it will prevent the progression of the renal problem or impairment. So there is no point in checking the hemoglobin A1C. It's too soon, premature to do that because patient just started on oral hypoglycemic medication. So it takes about 1 to 3, up to 2 months, 1 to 2 months for the hemoglobin A1C to have meaningful change or result. So the mechanism of action or of the ACE inhibitors to delay the progression of the renal problem, which is, in this case, that patient has a microalbuminuria. B is the answer. Dilatation of afferent arteriole decreases glomerular hypertension. So the angiotensin II, which is a vasoconstrictor for the afferent arterioles, the ACE inhibitors will inhibit the angiotensin II and dilate the afferent arterioles. And that will have a brief effect on decreasing the GFR, but overall, it will decrease the pressure and that protect within the kidney, so it will protect the kidney vasculature from damage. So B is the correct answer. Dilatation of afferent arteriole decreases glomerular hypertension. So nephropathy is a long-term complication of diabetes mellitus. And that's most common cause of end-stage renal disease, ESRD, in the US. And the early manifestation is the microalbuminuria. So the ACE inhibitors that will decrease progression to renal failure if started already at early phases. And the strict glycemic control and hypertensive control also will decrease the progression of the renal impairment. Now, metformin is contraindicated in renal insufficiency to avoid lactic acidosis. Metformin, glucophage, is contraindicated in renal insufficiency to avoid lactic acidosis. And also for the statin, since the patient on statin, is that everyone or all patients on statin should have an hepatic function test, LFT is liver function test, ELT, EST, check, bilirubin, but mostly EST and ELT, in addition to other liver function tests like bilirubin. Alkaline phosphatase also another one. So metformin, before we move on to the second case study, metformin um, should not be used in patients with kidney disease, liver disease, or heart failure, or in patients, not to be used in patients who drink excessive amounts of alcohol, patients who anticipate to undergo a diagnostic test with the use of any contrast media that contain iodine. They also should hold the metformin before, at least like 2 or 3 days before the diagnostic test, and resume it a day or two after, because that can result in lactic acidosis. So it should be discontinued before, like a day or two before the procedure, and resumed about like 48 hours after the procedure. Second case study, chief complaint, I'm here to follow up on my medication. Blood pressure 134 over 94, pulse 84, history of present illness, past medical history, medications. Initial orders is hemoglobin A1C, CAM7, liver function tests, urinalysis. So the microalbuminuria, which is caused by a loss of negative charge on the GBM, which is the glomerular basement membrane. The statins, they cause, one of the complications of statins is that they increase the liver function test. They cause LFT elevation. So the orders now amlodipine, which is a calcium channel blocker, as a second hypertensive agent. Sitagliptin, which is a hypoglycemic agent, which is the Januvia. In terms of medications, we should never combine an ACE inhibitor with a angiotensin receptor blocker. ACE and ARB, they do not combine. So under the orders also, amlodipine, sitagliptin, which is Januvia, and then continue lisinopril, atrivista, and metformin glimepiride. So where is the majority of the glucose absorbed in the nephron? It's a proximal tubule. 100% of glucose should be absorbed by the end of the proximal tubule. And that's why there should be no glucose entering into the lobe of Henle, and we don't see glucose in the urine normally. So normal result is no glucose in the urine. That's why most 100% will be reabsorbed back to the bloodstream at the end of the proximal tubules. And so some of the nephrons, they begin to saturate the um, SGLT, which is sitagliptin transporter, at about, we said, an 80 or 180 or 200. And that was called the threshold. So we said threshold about when the glucose reach over like 200, that's when we will expect or anticipate glucose to be revealed or seen in the urine, leaking in the urine. So at any time you see that there is a glucose in the urine, it indicates that the blood glucose level is over 200. So it is the mechanism of weight loss for DPPIP inhibitors, which is an example of that, which is the sitagliptin, which is the Januvia. This is just, that's the classification name of the drug, in the previous, one of the previous slides, this slide right here. Sitagliptin, which is Januvia, that is the DPP4 inhibitors. That's the classification of the drug. And this drug, the classification of the Januvia sitagliptin, or the class of the drugs under DPP4 inhibitors, the answer is A. So that's the GIP, slows gastric motility. So the GIP, which is the glucose-dependent insulinotropic peptide. Glucose-dependent insulinotropic peptide. The gastric motility is directly slowed by the incretins. There are other hormones we haven't covered in the endocrine system, but that's one of them is incretins. So the gastric motility is directly slowed by the incretins, like the GIP. GIP is one of the incretins. The old name for the GIP was the gastric inhibitory peptide. The exenatide, which is Byetta, that's also a synthetic GIP, produces significant weight loss by slowing stomach motility. So these drugs, the class 4 DPP4 inhibitors, they slow the gastric motility by the GIP. So the synthetic GIP produces significant weight loss by slowing the stomach motility. The calcium channel blockers, they can cause constipation because they can inhibit the intestinal smooth muscle. So the patient's current vital signs and lab test results are, that's blood pressure, less than 130 over 80. LDL less than 100, hemoglobin A1C less than 7%. So when the patient developed long-term complications from diabetes like neuropathy, they will be treated with a gabapentin, which is neuron 10. If they develop constipation or diabetic gastroparesis, which is slowing motility of the stomach and, and intestine, so patient will be started on the metoclopramide. Retinopathy, proliferative retinopathy, patient will undergo a laser photocoagulation to correct the problem. And these are some pictures of patients when they develop the um, um, retinopathy. Also for the gastroparesis, which is the decreased motility of the stomach, the motiline is decreased. That's why the patient will develop the gastroparesis. So they use the erythromycin because that will increase the motiline release. Erythromycin. Another case study, but this one on the prevention of complications. So the answer to this question is D, blood glucose level of 200 2 hours after completing glucose tolerance test with a 75 oral glucose load. The symptoms of polydipsia, polyuria, and weight loss are suggestive of new onset of diabetes in this young man. So the diagnosis of diabetes mellitus can be made in any of the following ways, because we have certain criteria to follow to diagnose patients with diabetes or to confirm diagnosis of diabetes, like a fasting glucose level of at least 126. And we talk about also the other um, tests like oral glucose tolerance test, and we talk about the impaired glucose tolerance and the fasting and all of that, and the hemoglobin A1C as well, and previous slides. So another case study. And the answer for this question would be B. Starting stand in addition to smoking cessation. So the history of acute coronary syndrome and diabetes places this patient at high risk for cardiovascular complications like acute MI, stroke, CVA. So the patient's diabetes, as well as the other risk factors, must be um, controlled in order to decrease this risk. The statins have shown or have been shown to lower the cardiovascular morbidity and mortality in primary and secondary prevention of cardiovascular complications. Niacin, while niacin would increase or raise the HDL, the good cholesterol, but there is insufficient data to support the recommendation of niacin to reach that goal in terms of reduction of cardiovascular events in patients who have known to have CAD. So the main goal for this patient is to should be to lower the LDL and total cholesterol to at least the recommended levels for patients at the risk of highest risk for cardiovascular disease or complications. So the emphasis should be on lowering the LDL to less than 100 and total cholesterol less than 200. Now, the answer to this question is E, controlling his diabetes. So although both hypothyroidism and diabetes are well-known causes of secondary hyperlipidemia, so hypothyroidism and diabetes both lead to secondary hyperlipidemia. So there's no mention of depressed thyroid function in this patient. So it would be unreasonable to start hormone supplementation without evidence of thyroid state. We didn't have any evidence that there is a hypothyroidism to start the patient on hormone replacement with thyroid, like Synthroid or levothyroxine. So controlling the diabetes would therefore be the only choice that would directly contribute to positively affecting his lipid profile, lowering the LDL and the triglyceride levels, and therefore it will decrease total cholesterol. Diabetes ketoacidosis. This is one of the, or a case study on diabetic ketoacidosis, DKA. Single most important test in DKA. The answer is pH, ketoacidosis. So the glucose level is not as important as knowing if the patient is acidotic. So the pH is the most important because the glucose levels can fluctuate wildly from high to medium. But if the patient's pH on ABG results or serum bicarbonate in chemistry is near normal, so it doesn't matter if the so the pH is most important. And same is important if the ketone bodies would increase in the blood. But the level of these ketone bodies is not as important as the level of accumulated acid. Glucose, ketones, osmolarity are not as important as the pH and bicarb levels. What is the mechanism of artificial decrease in sodium? So it's C, hyperglycemia, pulls water out of cells, diluting out the sodium. So because the hyponatremia causes confusion and hyperglycemia causes confusion, it is important to be able to address and correct the proper abnormality. Both of them, hyperglycemia and hyponatremia, both will result in confusion. So when the glucose levels markedly increase, significantly increase, it pulls water out of cells. And because the total number of sodium molecules do not change, the extra water in the vascular space drives the sodium level down. The mechanism of hyperglycemia, A, which is transcellular shift for acid. When the acid, and this is a mechanism we constantly discuss this in pathophysiology, when the acid or the hydrogen ion build up in the blood, the majority um, of the cells in the body buffer the acid by absorbing that acid. So to maintain the electrical neutrality, it's become like neutral, electrical neutral neutrality. The cells will release the potassium for an exchange with the hydrogen ion. So that exchange between the potassium and hydrogen ion will result in hyperkalemia. Because in acidosis, there is an excess of hydrogen ion. The difference between venous pH and the arterial pH, we can say it's equal. If there is no respiratory disease, the both arterial and venous should be essentially equal. The difference is very minimal, negligible, very minimal. So we can use venous blood gases to monitor the DKA response to therapy. As we treat the patient for DKA during the DKA episode, we can draw the venous instead of arterial, as long as the patient doesn't have any respiratory problems. So the mechanism of confusion in DKA, which is C, hyperosmolarity dehydrates brain cells. So serum osmolarity is usually dependent entirely on serum sodium content. So in severe hyperglycemia, the extremely high glucose level acts as an osmotic draw on the brain cells, and this dehydrates the brain cells. So the brain doesn't think well with high osmolarity, as the water is being sucked from the cells, brain cells, and also the brain will switch to use the ketone bodies for as a fuel, as a source of energy. After 2 hours, the patient's lethargy resolves, normal mentation returns, and then these are the blood levels of glucose, potassium, bicarb, and pH. What is the major change you expect to be made in the management of decay for this patient? The answer is C, add potassium to fluids. As the potassium starts to drop into the normal range, add potassium replacement. So you add more potassium. You expect the patient to receive potassium at this point. And that's because the body becomes massively depleted of potassium. There is a potassium depletion, and that's because of the metabolic acidosis. Acidosis takes potassium out of the cells. Um, uh, High blood potassium is excreted at the kidney. That's to protect the heart from fetal dysrhythmias. And when acidoses are corrected, then potassium shift back into the cells and blood vessels will drop below normal. So during the acidosis, potassium is excreted from kidneys. Question about the DKA. The answer is B, increase the IV rate, consult the provider about the potassium. So patient developed the DKA because the body, in the absence of insulin and able to use the glucose as a source of energy, they will lean into the fat molecules, and that will be the source of energy, the fuel, and then the byproduct will be as the ketone bodies, and that will make the blood acidic, and that's the diabetes ketoacidosis. So another case study. The most likely diagnosis for this patient is diabetic retinopathy. Diabetic retinopathy, which is the result of the microvascular retinal changes due to diabetes. High blood sugar lead to changes in the basement membrane in the retina and result also in a microvascular small blood vessels that will rupture and result in hemorrhage. This next step in the management for this patient is a pan-retinal photocoagulation. And that's the best next step in the management for this patient. They will do hundreds of burns with laser therapy in the retina. And the goal is to reduce the retina's oxygen demand, which will reduce the chance of ischemia in the retina. Vitrectomy will be done in patients or used when patients has less hemorrhage in the retina. So miscellaneous questions. The answer for this question would be 3, because the insulin is administered as a sub-Q injection, and that's shown in this illustration number 3. Number 1, which is intradermal administration technique. Number 2, which is a Z-track, intramuscular Z-track administration technique. And number 4, which is an intravenous, as you know. Next question here is, answer is C, cardiac rehabilitation or cardiac rehab. It will include, when we say cardiac rehab, include progressive exercise, diet teaching, classes on modifying risk factors. So this supervised setting would be the priority intervention for this patient when the client is discharged from home health. Next question. Frequent urination, hyperglycemia, slurred speech, hypoglycemia, blurred vision, hypoglycemia, dry mouth membrane, that's hyperglycemia, and then same for rapid and deep respirations, that's hyperglycemia. Next question. Blood glucose 54, patient's lethargic but arousable. Now this is a ranking question, priority question. You would first you would give 15 to 20 grams of carb, then recheck blood glucose in 15 minutes, and then you will give 7 grams of protein, and then you report episode of the to the PCP or the provider. So when we say for this question, the greatest risk to the client or patient is the lack of glucose for cell metabolism. So the priority action is to give the 15 up to 15 up to 20 grams of carbs. It can be 4 ounces of orange juice, or for 2 ounces of grape juice, or 8 ounces of milk. That's all equivalent to 15 to 20 grams of carbs to raise the patient's serum blood glucose level to normal levels. And then you recheck in 15 minutes blood glucose. If blood glucose remains below 70, then you give a 15 gram of carbs, and then you recheck the glucose in 15 minutes and repeat until the client's glucose is above 70. And you will follow after that with 7 grams of protein. And then you report it to the provider. And each setting or hospital, they have their own protocol for hypoglycemia. But patients who are unconscious or unresponsive, or patients, then we have to, once the patient glucose level is less than 70, then patients are unresponsive, unconscious or unresponsive, then you will give glucagon IM or sub-Q injection, 1 milligram IM or sub-Q. Next question is the about the Humalog insulin, 15 units sub-Q at 8. So administer the medication when the breakfast tray arrives. This is a rapid-acting insulin with an onset of less than 15 minutes. The onset of less than 15 minutes. So administering the insulin at the time the breakfast tray arrives will ensure adequate blood glucose at time of peak action. So the patient's blood glucose should be checked prior to insulin administration to prevent so we can prevent any episode of hypoglycemic event. And usually it's the drug that is used as to cover patients' hyperglycemia for those who are on the sliding scale coverage. Number 4, answer is A. Give 2 injections by drawing up 8 units of regular insulin in 1 syringe measuring the 14 insulin of the glargine in another syringe. In one syringe, for insulin syringe, you will draw the 8 units of regular insulin, and a separate one, the 14 units of insulin glargine. So you give two separate sub-Q injections. Because these two medications, the insulin glargine and regular insulin, like Humalog R, they are not compatible and cannot be given in the same syringe. So we have to be careful about which medications can be mixed and or given in one syringe. Sometimes you have patient on the same short-acting medication, Humalog R, and then the same drug or the same insulin for coverage, and the same insulin also will be given as scheduled dose. You can combine them because that's the same medication. Coverage for 4 units and then scheduled for 6 units. You can combine it as 10 units and give it once. That's fine. But here we have two different insulins that should not be combined. These two medications are not compatible and cannot be given in the same syringe. Number 5, the type 1 diabetes admitted to the hospital. Then this is another ranking, prioritization or ranking in terms of the interventions. So you'll take the vital signs, then you perform the glucose, the echo check, which is finger stick, and then you will administer the insulin, the morning insulin injection, and you complete the morning data collection, assist with breakfast tray, assist with morning care and grooming, and then reinforce teaching the client about complications of diabetes and circulation. So the nurse should collect the patient's vital signs and then check the patient's glucose level. You administer the insulin approximately like 30 minutes prior to a meal, prior to breakfast. So give the insulin after the blood glucose level is checked. And then you will complete your morning data collection and then assist with the breakfast tray and then complete the morning care and grooming. And then lastly, you will reinforce the patient teaching about medications or complications and the complications of diabetes mellitus when there is adequate time, and then when the client is not tired or distracted by other activities. Next question, answer is C. Risk factor of diabetes, diabetes increase the risk for development of cardiovascular disease. Next question, I'm sorry, is B. Your brain needs a constant supply of glucose because it cannot store it. Next question is, answer is D. It prevents hypoglycemia by promoting release of glucose from liver storage sites. And the answer also for the second one is D. Serum osmolarity 375 millismol. Next, the answer is C. Protein in the urine during the random urinalysis. Answer for next one is D. Diabetes can cause blindness, so I should see the ophthalmologist yearly. So annual eye exam is a must, and it's recommended for diabetic and hypertensive patients, given the retinal changes and the visual or eye problems that would result from the hypertension and diabetes as a long-term complications from that could result from these two diseases. Next Question, the answer is C, examine the client's feet for signs of injury. Next one is, the answer is A, your risk of diabetes is higher than that of the general population, but it may not occur. Next question, the answer is A, control hyperglycemia. That's the most important action. And then the last question, the answer also is A, check urine ketones when blood glucose readings are high for anticipation or to rule out a DKA or HHNKS, which is long-term hyperglycemia, which is acute complications, not chronic complications. DKA and the HHNKS are acute complications. So that will conclude our lecture on diabetes.